Good morning, everyone. We're going to get started. Today, we are privileged to welcome Dr. Lucy Ogbu-Nwobodo and Dr. Pierre-Cedric Crouch. Dr. Nwobodo is an assistant professor in the Department of Psychiatry and the medical director of UCSF Alliance Health Project. Dr. Crouch is a nurse practitioner at UCSF Alliance Health Project, and we are so lucky he provides psychiatric care for our patients at Ward 86 and in our pop-up program down in Ward 81. They both have a tremendous wealth of experience and expertise providing psychiatric care for people living with HIV, and we're truly honored to have them share their important insights on this topic. Thank you, and please join me in welcoming them.
Perhaps I can have Pierre come up for a second. We can just both say hello as we get started. Thank you so much for having us this morning. We're really honored for the invitation. There's so much to cover in a very short period of time, but we're really hoping to have a lot of time at the end for audience interaction and questions. So please, feel free to ask us questions. We would love to hear how things are going from your side of things. And if we can expound on any components of what we covered, we're more than happy to do that. Perhaps I can just have Pierre say hello.
I'll just say hi. Hopefully y'all remember me. I'm a Psych NP now, which is crazy. Instead of learning how to do bread during COVID, I actually went back to school to be a Psych NP. So I appreciate being here to talk about psych. So, all right, welcome.
So we don't have any relevant disclosures, and we have a lot of objectives today. And as I mentioned, some of this we may have to have perhaps a more cursory discussion in the earlier parts, and then we can expound more as needed based on your interest. So we're going to talk about HIV, depression, and some considerations for difficult to treat depression. We'll discuss managing substance-induced psychosis, which is something that we've seen a lot, especially as we have a lot of substance use disorders in our community. And then we're going to review some interesting new mental health medication that has come out in the last couple of years. There's some really exciting ones that would really be helpful for people to be aware of. And then we'll have an open site, curbside questions for you guys to hit us with all your questions. Without much further ado, I'm going to get started. So HIV and depression, I think this is something that I really wanted us to talk about quickly today because it's something that's so impactful in this population. So we're going to have just a quick overview of what that is, thinking about also the current evidence and really emerging information of these in the literature, linking neuroinflammation as a potential contributor to the high prevalence rate that we see with depression and those living with HIV. As I mentioned, we'll look at treatment strategies. So depression is the most prevalent neuropsychiatric disorder among people living with HIV. Up to 50% of HIV participants in many studies report having depressive symptoms, and the risk of depression is twice as high than that of the general population. So we really have something that affects many people. If you imagine 1 in 2 of people living with HIV have significant clinical depression, we need to be really mindful and be able to be proactive in how we assess, screen, and also treat these folks. So, we'll be remiss not to talk about the fact that there are considerable psychosocial factors that can really compound and exacerbate the higher rates of depression that we see with those living with HIV. This is something that I feel like I'm preaching to the choir here, but we do know that people living with HIV suffer from many challenges, whether it's isolation, lack of societal and social support, stigmatization, discrimination, and social attitudes towards gender minoritized folks, violence, hopelessness. All of these things can contribute to depressive symptomology. And then furthermore, we know that those that are significantly socially disadvantaged, marginalized, and disenfranchised are already at greater risk for depression. And these folks are overrepresented among those living with HIV. When you think about your racial and ethnic minoritized folks, those who are socioeconomically disadvantaged, LGBTQ+ folks, those impacted by SUDs, all of these folks and more are really at risk already for depression, and then they're also overrepresented among those that have HIV. And so I wanted to show this and sort of have a quick discussion on this, but happy to take more questions at the end. But this is a rather complex image, but really it comes from this, wonderful paper that I was reviewing recently. And it showed, schematically, the ways in which what we know about neuroinflammation, which is this collection of immune responses that happen in the CNS, characterized by microglia activation and release of multiple inflammatory cytokines, might actually be involved in the etiology of depression. We know that HIV itself is already an inflammatory condition and can increase these cytokines in the body, and retroviral treatments can actually decrease circulating cytokines. And a lot of recent emerging literature shows that depression itself has a unique inflammatory subtype where we know that you have elevated, inflammatory cytokines and other hormones that are high in people with depression. And there's been some recent studies looking at how anti-inflammatory medications can actually improve depression. With all these things linked, we're seeing that the association between depression and inflammation is quite high. And since HIV itself elicits neuroinflammatory response, there's really some strong data looking at the fact that this could be contributing to the high prevalence of HIV-associated depression. Now, these studies are emerging. There's a lot more work to be done. There are components we have to figure out, including, how we can actually have consistent and validated biomarkers, treatment interventions, and other ways if we're able to have more elucidation in this process. So stay tuned for this, because I think that's going to be a very interesting area of research in the next few years. So the most prevalent symptoms for HIV depression are insomnia, anhedonia, this loss of interest, fatigue, loss of appetite, and difficulties with memory and concentration. I think it's important to know how it presents with those that have HIV, as I'll share in another slide just really quickly. The DSM-5 criteria for depression is very long, and for folks with HIV, it can present, according to literature, the most prevalent symptoms are the ones highlighted here. SI, suicide ideation, is substantially higher with people living with depression, and this is consistent with these high rates of depression that we're seeing. And as you can imagine, as I'm sure you've seen clinically, having depression and having HIV impairs quality of life significantly. We have, intense psychosocial impairment, minimal adherence to your therapy, your heart, and also it impacts how the outcome of the medication is being seen in the body. And one thing I want to also highlight, as I mentioned before, all of these intense psychosocial stressors already itself prime your immune system and create active inflammatory processes in the body. And that can synergize with what's already happening with HIV to impact folks and cause depressive outcomes. So this is a really complex process, and it's important for us to really appreciate how it can impact our patients. And so, like I mentioned really briefly, the DSM-5, some of you may already know some of this, has this criteria for MDD, major depressive disorder, and folks have to meet 5 or more of this for at least 2 weeks, with having depressed mood or loss of interest being one of those criteria. And notable that the symptoms have to cause significant distress or psychosocial impairment and are not direct result of a substance use or general medical condition. So I think with these folks, it's also really important for us to look at potential medical comorbidities that could be affecting folks, whether it's endocrinological, metabolic, and other ways that may be treatable that can actually improve their symptoms. So we have a question, a scenario that I'd love to engage with you guys on, and this would lead us to think about more treatment interventions. So we have a patient who's 42 years old, woman, female, has a history of HIV, came to her PCP, and reports really persistent low mood, lack of interest in her activities, and significant weight loss with poor concentration and sleep disturbances over the last 6 months. She feels hopeless and is having recurrent thoughts of death. She's also on a pretty high dose of Zoloft for about 3 months and has a history of recurrent depression, for which she has been treated for in the past with different meds. She thinks she's been on Celexa, maybe one other medication. She's not really sure. And though some of these medications may have given her relief in the past, the benefits were usually short-lived, and she hasn't really had sustained improvement. So the question for you is, what is the appropriate next step in the management of her depression? And the poll everywhere might be on. Okay, great. Oh, yes. I wanted to have one that encompassed all of the above because these are multiple steps that we can think about in the person that's coming in front of you. And I think first and foremost, when we're thinking about folks' experience with medication, we have to center the person in front of us, really trying to understand, what is their experience with the medication? Are they actually taking it as prescribed? What is the actual adherence? And importantly, what is the therapeutic alliance between you and the patient? Because we have seen that how a patient relates to their provider can actually optimize their adherence. And sometimes folks will not be, feeling vulnerable enough to share with you that they're not really following your instructions because they don't trust the dynamic that has been established. So really reviewing that is really important. And then checking to see if there are other diagnosis that may actually be more optimal in this case, because sometimes folks have MDD as a diagnosis, but they're actually dealing with something called bipolar depression, which is a whole different type of depression that needs a different kind of medication. And with bipolar depression, it's important to think about the fact that it comes in very severe phase, and it also has this temporal on and off nature of it. And it has these periods of mania and hypomania that sometimes people aren't really fully aware of. So we're doing a lot of intensive discussions about what is really presenting for the person to know if we have the right diagnosis. And bipolar depression has a high suicidality rate of up to 15% of folks. So really making sure that we're actually ruling other things out, checking if there are other medical issues going on, thyroid, endocrinological issues. Do we have people that are, actively using substances that may be confounding their clinical picture? And so all this is important in establishing what we do next. And then based on the literature, and there's many studies on this, one of the biggest one was a STAR-D study that looked at how do we do a stepwise intervention with those who have resistant depression. And one of the first options is switch to a non-SRI antidepressant. Sometimes you can actually switch within the same class. So some folks may not do well on Zoloft, but they will do well on Lexapro. So it's very good to actually check and see if you want to try within the same class of medication. Checking side effects is really important because some folks may have really profound side effects that they don't want to talk to you about because it's quite sensitive. Sexual side effects is one of those ones. People may have GI symptoms that are really, really hard to take, a lot of nausea and vomiting. Some people may have some weight gain and other factors. So really trying to see if side effect burden is overwhelming, because if you make medication changes, they may actually have better tolerability of that and have better adherence. But there's been some really good studies looking at switching to a non-SRI. So for example, bupropion, mirtazapine, also known as Remeron, and then venlafaxine. And I can't say this enough, right? Really thinking about, could we refer folks to psychotherapy, right? There is a lot of evidence that shows that medication and psychotherapy together actually have better improvement in outcome. And the psychotherapy could be CBT, could be other interventions, but thinking about other resources that we have out there. And with telehealth being what it is now in this post-pandemic era, there's a lot more for some folks who are unable to go to therapy every single week and get out of bed and go somewhere to hop on a call, hop on a Zoom, and still get really strong benefits of that. And so let's talk more, like I mentioned, just thinking about how do we treat folks that are dealing with difficult to treat depression. And I put that in quotations, and I'll share with you a little bit why. So this idea of TRD is really complex and hard to really have a universally thought about definition. There's 155 definitions of treatment-resistant depression in the literature, and that's what's published. So it's probably exponentially higher than that. But for the purpose of this event and for what the current guidelines are, TRD is seen as an inadequate response to 2 or more antidepressants from separate classes within 4 to 6 weeks after the target dose has been reached. And I think it's important that there's been evolving discussions around calling this difficult to treat depression versus treatment-resistant depression, because people want to minimize this thing called therapeutic nihilism, where we kind of have this almost hopelessness and pessimism about someone's ability to actually get better. So by saying resistant, it almost sounds like we're like, oh, this is never gonna, it's never gonna get better. There is evidence that folks sometimes with different trials do get better. So it's important that we try to think about how our language may also be impacting how patients are experiencing the condition and how we as providers may feel about it. If it's resistant, why am I even bothering trying, right? And so there are additional risk factors for TRD, and I'm calling it TRD because the literature is calling it, but I think we should probably think about difficult to treat as a potential way of calling it that. So there's comorbid general medical conditions. So folks that have, heart disease, diabetes, chronic pain, which is something that's really important to talk about potentially at a different time. Poor pain management can lead to a lot of affective instability, hypothyroidism. Other medications can actually, impact folks' experiences with their mental health. Having other psychiatric conditions like anxiety, personality vulnerability, substance use disorder. Really, the intensity of the depressive symptoms can also impact the risk factor, suicidality, and having adverse life events, right? When life happens, it can really hit really hard for many people. And in those acute periods can cause severe depression. And then the recurrence of the depressive symptoms, and those that have an earlier age of onset when they were diagnosed with MDD have an increased risk for being difficult to treat in our literature. And then loss of employment and low SES. I think sometimes I tell people a lot that poverty is a disease that we have not found a way to fully treat, where people are presented in front of us, right? And they have what I call profound societal ills. And as providers, we're being told, now treat this. So there has to be a lot of ways in which you think about how to leverage and engage other systemic and structural interventions to help those presented in front of us. And medication can't treat homelessness, and medication can't treat, poverty. And so we're gonna have to think about other ways to think about our work as medical providers involving a social advocacy lens. And so, the recommendations, again, really thinking about combining psychotherapy in what we're doing pharmacologically, and then some other considerations. And, it's interesting because they're not really in order of evidence, because evidence has there's evidence for all of these, but I'll just talk about each one in sequential order as is on the screen. So switching therapies, so like I mentioned before, changing different class or the same class, and thinking about what may have impacted their ability to be on that other medication, and combining the current meds, so combining maybe an SSRI or an SNRI with one of the following. So there's a very strong evidence for antipsychotic augmentation, particularly with Abilify, also called aripiprazole, at a low dose, actually. So 2 to 10 milligrams of Abilify can actually be seen as potentially augmenting and effective for these patients. Of course, with any neuroleptic therapy, being mindful of metabolic impact and really following that through. Quetiapine is also one that has been shown to have benefits, but of course, with all of that, that one has a higher weight gain profile as well. And so thinking about other additional antidepressants, mirtazapine, bupropion, and being mindful also, if we're combining antidepressants or together, being mindful of serotonin syndrome, right? This can happen when we have two, SSRIs or even SSRI at a higher dose. So I think being vigilant on how we're dosing these folks and just watching for other symptoms. And then augmenting with lithium. So lithium is something that a lot of people have very strong fear of, because it is a medication that has potential, side effects profile that can be really scary. And you have to really track it with the plasma levels to ensure that you're at a safe level, and being mindful of those that have history of, thyroid disease, people that have history of renal disease because of the impact in renal toxicity, and also making sure that you're getting, some baseline labs with all of these as you're tracking these folks. And then thyroid hormones, T3 specifically, has been shown to be very effective at, again, 20 to 50 microgram dose. Again, being mindful that not everyone can take this. So people that have adrenal insufficiency, people that have diabetes, cardiovascular, history, and checking, TFTs over time as well. So some of these things will require some delicacy in management, but there are some really strong evidence that they can actually help optimize the depression for these patients. And this is not at all inclusive. There's a whole much more medications out there, but we're just gonna offer briefly some of the high yield ones in each of the more typically used classes, and their starting dose and usual dose. Again, with all of these things is individual based. Tetracyclics are used less because they're quite cardiotoxic. However, there's some evidence that they can actually be helpful for those who have failed other classes of medications. So again, something to consider. And they can also be used for folks that are dealing with, chronic pain and other comorbidities as well. And so I'll pass it on to Pierre to talk about SIP. But before we do that, we're going to have some questions at the end. So just want to also, make sure we know that. But if there's any quick burning questions for now, I could take some, but want to also give time for us to have our little curbside consultation with the audience.
Great. We'll see if there are any questions from the audience just for a minute or two, none from online. But anyone have any questions?
Please. Oh.
Hi there. Thank you, Lucy. Can you talk to us about how you discuss with patients who may be feeling stigmatized by the addition of an antipsychotic to their depression regimen?
Thank you for that question. I think it's something that every month I'm, engaged in a discussion with someone. It's important to really explain to folks what the medications do outside of the name, right? Because one thing I've heard from people, antipsychotics, someone told me, does that make me a psycho? And there's a fear of, being looked at differently or being denigrated because we have this psychotic component to it, right? I tell folks it's a medication that has multiple indications that can do multiple things. It can be used as a mood stabilizer. It can be used as, depressive adjunct. And so trying to really be thoughtful and hearing what's coming up for them first, and then sharing what we do with these medications and how they can be helpful. And then sharing about the side effect, profile too. We are worried about certain things. And so that's why you have to have this informed consent process of the risk benefit analysis. And it will vary based on each person. You can always try it, see how you feel on it. Nothing is ever have to be permanent, right? If you don't like it, we can think about how we can modulate accordingly. But it could be multiple visits, to be honest, never just one, and keep revisiting and see where people are, especially as their symptoms are getting worse. People are sometimes more open to trying new things. And also, again, being able to sit with where they're coming from is really important.
Two more questions from the chat. So when do you check an EKG with the various psychiatric medications?
Yeah, so great question. So Paxil, I can never say that word right, was really seen as one of the more cardiotoxic SSRIs. And so it's not as used for, commonly. So for most SSRIs, I'm not checking an EKG. However, if you're on TCAs, like I mentioned, I can go back a little bit. Amitriptyline, nortriptyline, those are definitely important to check. And of course, if you're having someone start on, lithium, it's important to have a baseline cardiovascular history. And so for that, I would say definitely. But for SSRIs and SNRIs, I'm not typically checking EKGs.
Okay, very helpful. And then one final question for treatment-resistant depression, a lot of patients are asking, are they eligible for ketamine? How do you assess that?
Yes, I thought I had a slide on this. I thought I had a slide. Sorry, I had a slide on this. So I had a slide. Thank you, whoever asked that question. So yes, we had a slide on other TRD considerations. One of them is esketamine, Spravato, as it's called, which is a newer medication that's an inhalant. But it's important to also think about the fact that access is really hard for people. There's some concerns around some of the safety of it, given some of its sedation and dissociative symptoms, and also as part of a REMS protocol. And so, of course, with every emerging, therapeutics, we want to increase access to it. But the issue is that there's a lot more barriers for some people to get into that care. Something else that I discussed in the slide that's not here is TMS, right? Neuromodulation as an intervention. There's been a lot of evidence showing it can actually be really helpful with TRD, but the frequency of course, which is 5 days a week for several weeks at a time, the fact that you have to actually have insurance coverage that sometimes people get denied and the prior auth is insane. And then also access to who does TMS. So all these additional barriers is really challenging for patients. It's important for us to talk about the fact that, there's a lot of, I would say with emerging science and therapeutics, we know that those that are disenfranchised and marginalized have less access to that. We have to really think about ethical interrogation of how we're creating access to these medications and interventions, because those that are poor, those that are minoritized, they don't get access to these benefits of science. And so we have to, as a system, really push ourselves to, really think about how do we create more equitable access for all, while still looking at the safety profiles, which is emerging.
I'm so glad that you brought up ketamine. And along those lines, I know there are barriers, but I think we've all had experiences with low-income patients in our clinic where if you push, you can get it done and can get it covered. And we all have, I have a case of a guy who I'm convinced is alive because of this. So it can be done. So you're right that there are barriers, but I think we all need to know that our social workers are amazing and can navigate ways, including using AIDS Emergency Fund to help pay for co-pays along the way, because ketamine for the right people can be absolutely life-changing. I was shocked to see this on a firsthand basis. So I really appreciate you putting that in context, but we can't stop pushing for these folks if they need it, as you say.
Absolutely.
You had someone who was on ketamine and Medi-Cal, and you found a place to do it?
He didn't get it. It wasn't paid through Medi-Cal.
Okay, yeah. I think that's the one there. So esketamine is covered by Medi-Cal, but there are no licensed Medi-Cal only providers who are doing it in the city, as far as I know. And I think that's the holdup. And so now you have to pay for it, or you do racemic ketamine infusions or treatment elsewhere, or you do Mind Bloom, where people go online and get lozenges, and then we all show concern to them doing that, but they're doing what they need to do to get access to it, and so it's not perfect. Yeah.
And just so there's a lot of pop-up ketamine clinics and a lot of pop-up unregulated setups we have to be really mindful of. Not every clinic has the licensed folks who are well equipped to think about the safety considerations here. So people can be harmed in some of these settings. I've seen it. And so with every new thing, when venture capitalists get involved, when there's a lot of people think about how we commodify healthcare, it can get to be a wild, wild west. So actually being able to caution your patients around going to places that have some regulations, some licensed providers, some way of showing safety considerations, because there are things that are happening in literally hallways, and it's very scary out there. Thank you.
All right, thank you. We're gonna move on and we'll take some more questions later.
Hello.
Thank you so much.
Right on time. It's all great. So, yeah. So I'm excited to talk to you a little bit about substance-induced psychosis. Though I always have to take a moment to reflect of my little 18-year-old gay boy self growing up in the South, who was part of the Just Say No generation, who is now totally talking about drugs, psychedelics, and mental health. It just boggles my mind. So, but here we go. So we have a little poll here. This one's gonna be a little bit tricky, but your first question is: you have a 30-year-old cis male living with HIV presents with visual and auditory hallucinations. They've been smoking meth and cannabis since age 15. Which of the following findings would best help in determining a diagnosis of substance-induced psychosis versus schizophrenia? Is it the presence of visual hallucinations? Would you stop meth and wait 30 days and see if the psychosis resolves? Would you assess what age when the psychosis first appeared, or assess for the presence of negative symptoms, which is described social withdrawal and affect deficits? Pick one that you feel is most right. And how much time do we give them to answer? Just, I don't know. Hopefully y'all feeling it. You locked in, you're confident. There are no grades with this, so it's all good, but we'll see what people said. See, we got a couple of ones. So yeah, so we have the presence of visual hallucinations, a couple of folks, the age when psychosis first appeared, and also for the presence of negative symptoms. They're all sort of correct, but this is like a nursing school question where one is more correct than the others. And the more correct one is the assessing a presence of negative symptoms, and we'll talk about that. So to figure out substance use psychosis, we have the DSM-5. for better or worse, doesn't give you a whole lot of great help. How they define this is that you're developing psychosis within a month or so of substance use. So there has to be a time link to it. The substance that they took can produce psychosis. So this isn't like ibuprofen. Like they took something that can cause a psychosis. It's not better explained by any other mental health conditions. So that would be like pre-existing schizophrenia or other things like that. They also tell you that mental health conditions, that the mental health condition persists 1 month after stopping, which is a lie, and we'll talk about that. And this also doesn't include delirium. So delirium can kind of present as substance-induced psychosis. So you want to make sure you rule out delirium first. I do want to talk a little bit about a couple of common substances that we don't always think about that cause psychosis. With the new legalization and spread of marijuana, we've been able to kind of study and see there's a stronger link with these higher concentration products of THC that are greater than 10% and synthetic cannabinoids, and particularly in people who are under the age of 25, because your brain still develops during this whole entire time and you're not really like done until you're 25. And so if you hit your brain with a lot of THC during that time, it increases your chances of psychosis fourfold. So you'll see an increase in like schizophrenia in people who were smoking high concentration THC when they were like 15, 16, or 17. So the harms of marijuana are real. I'm not telling you like how to regulate it, but for folks under 25, it is definitely something that they should sort of consider and limit their use to reduce their chances of psychosis. Meth, I think, is the one thing that we see a whole lot. About 20 to 25% of people who are using meth are going to have psychosis, and that's common. That makes sense. I think that like makes us all feel good. And then the one that we don't really think about as much is like prescription amphetamines and methylphenidate. With the huge increase in prescribing these from like ADHD diagnosis, some of it from those shady online places, you can get psychosis from these medications. It's not very common, but it's possible. You can see it's only like 0.2% and 0.1%. It's not zero. The main controversy about that, or what's sort of difficult to pull out, is that you don't know, is it really the drug causing it, which it can, or is the drug sort of like unfolding or like, uncovering underlying psychosis that was there. So some of these medications can uncover an existing psychosis, and some of them can just cause a psychosis. And then we're also seeing things with like mushroom psilocybin that's actually more accessible to folks now. DMT, LSD, cocaine does this as well as like cat and bath salts can cause substance-induced psychosis. So there's something to kind of be aware of. People don't always like tell you they're on these because what ends up happening is someone says that they'll use something and then it gets into their medical record and it gets everywhere. And then people were like, I told you I smoke pot and now you put me on a cannabis use disorder, which is not how you do that. So just make sure you establish a good relationship with folks and explain why you want to know what they're doing and chart accordingly and non-stigmatizingly. So if you're trying to sort it out, there's a couple of things you can do to try and figure out like which is which. Schizophrenia, the main thing that like separates it out from substance-induced psychosis is that it's a pronounced thought disorder problem. Their thinking is off. And while you're intoxicated, yeah, your thinking can be a little bit off. That sort of goes away. It's not a persistent thing. So your thoughts are disorganized when you're living with schizophrenia. You also have more prominent negative symptoms. So with schizophrenia, you have what we call positive symptoms. That's that psychosis, hallucination, delusions type stuff. And then you have negative symptoms, which is that social withdrawal, that affect blunting that people have. When you're using substances, you're not going to have those negative symptoms. You'll have a lot of those positive symptoms. And another thing that kind of comes up that's I don't think we like do a good job teaching is like when does schizophrenia first start? So oftentimes people are just taught that, things start for, if you were assigned male at birth, it's going to start in your early 20s, late teens to early 20s. Assigned female at birth, it's like 20s to 30s, so it pops up a little bit later. But there is something called late onset schizophrenia, where people can get it in their mid 40s or a little bit later than what we expected. So while you can use age to kind of like sort of figure out like maybe if they were like 60 or so, it'd be like less likely, but it doesn't fully exclude it from that diagnosis. And anytime you have a substance-induced psychosis in the past, it can uncover underlying schizophrenia. So you can have a substance-induced psychosis episode, recover it, be fine, and then later develop schizophrenia, and having that episode put you at higher risk for it. When you look at things like substance-induced psychosis itself, 25% of people have persistent symptoms or psychosis after 1 month. So that 1 month thing that the DSM teaches you is actually not correct. One of the things that you also can look at, substance use psychosis gives you more of a visual hallucinations. Schizophrenia also has visual hallucinations, but they're generally primarily auditory for most folks. It's not a hard and fast rule, but if someone really just came in and had only visual hallucinations, that would argue more for like a substance-induced psychosis type thing, including as well like tactile hallucinations. That tends to be more substance-induced in sort of schizophrenia. But I also just want to ask like Lucy if she had any like sort of tips on how do you sort these out? Or
yeah, I think it's so complicated because sometimes people tell me I've been completely off of name the drug, right, for a year or two even, but I'm still having these symptoms. What's going on, doc? Right. And so there is actual literature showing that 32% approximately of folks with SIP end up converting for schizophrenia spectrum thought disorder illness. And that's a really high number, right? Sometimes, yes, there's already maybe underlying vulnerabilities in the substrate in the brain. However, for many different reasons, and again, it's very heterogeneous, evolving space in research, people end up having chronic thought disorder following these experiences. And sometimes people have full remission, but it's important to like also have, sort of set expectations for folks, right? Like it may not go away permanently and it may get better with treatment that we'll talk about. There's a ways that we can mitigate the impact of some of these experiences with folks, though I've seen a number of my patients who have been completely off of all drugs and are still having psychotic experiences. And so that's a very challenging component of that. And then just really quickly on the late onset schizophrenia, I think that's an area that really people don't talk about a lot. There are people in middle age who are getting diagnosed with schizophrenia for the first time and have never had before that a history of thought disorder. These folks do tend to have less negative symptoms and they have a higher pre-morbid functioning. So they have a much higher history of, being able to have sometimes higher education, higher work history and all those things. And then suddenly in their middle age get schizophrenia. And actually folks that are assigned female at birth, women tend to be higher risk for late onset schizophrenia.
So at the end of the day, like my advice, you don't have to really sort of sort it out in that moment. You just treat symptomatically. So like you can figure that out later. There's technically no data on managing long-term substance-induced psychosis for someone who's like on meth and they have psychosis and they're still using meth and that's kind of going on. We have no data. A lot of the data is all about like, oh, I use meth and you're in the ED and like, how do we kind of calm you down and get you back to a good spot? But no one's really looking at what happens afterwards. But if you have a low suspicion for pre-existing psychosis, these are the times where you're going to use sort of as needed doses of antipsychotics. You're not going to put them on like daily dosing. You're just going to like, get them back to normal after their weekend. And hopefully after 3 or 4 days, things are okay. But if you have suspicion that there's an underlying psychotic disorder and they have ongoing psychosis, that's where you want to consider doing more daily dosing or looking at long-acting injectables for those folks. But the big question comes up like, well, how do you pick an antipsychotic? There's a whole article, if you want to go look this up, where they kind of compare every single one by all sorts of different classifications. If you want to go geek out over it, you can like look at which one gives you better prolactin levels or whatever else like that. But I wanted to make this sort of better, short and sweet for you. And this is how I conceptualize antipsychotics. When we're looking at how well they control positive symptoms, so that's the hallucinations and things like that. If you rank the ones, and these are the ones that we like most commonly use, there's a bunch of other ones, but things like clozapine, risperidone, olanzapine, and paliperidone are like some of the best ones at controlling the positive symptoms. But you see, as we go down the list, you got Haldol, ziprasidone, and then take note, quetiapine, aripiprazole, which we use a lot, is much lower on the list, as well as lurasidone and cariprazine. And then if, with every one of these little medications, it comes at a cost. There's side effects associated with it. So if you took that sort of similar list and like flipped it up and be like, what about like metabolic side effects, which is one of the primary things we worry about with these, the list is almost upside down. So things like ziprasidone, lurasidone, aripiprazole, take note of that, are some of the better ones metabolically for folks. They have other pluses and minuses, but like for metabolic purposes, aripiprazole is one of the nicer ones that we have. And then as you go down the list, you'll see the ones that are like, more effective have worse metabolic effects. So like risperidone, paliperidone, clozapine, quetiapine, and olanzapine is the worst one that we have. So, actually, do you have any comments though? How do you conceptualize your antipsychotics, Heather?
Yeah, I think, looking at this list, things like clozapine can be really hard for patients. And Pierre will talk more about that, given some of the requirements. I think, though haloperidol is right there in the middle, I do think there's been a movement against using first-generation antipsychotics because they have really severe extrapyramidal symptoms that can be very profound. And interestingly, there's been some actual interesting data on the disparities of who gets offered first-generation versus second-generation antipsychotics. Black folks are still being offered haloperidol, despite its really high side effect burden in this day and age compared to what we know are safer. So I think it's important for us to think about as well as a system, who gets prescribed what, and how it may be impacting folks in the long term. But it really can be sometimes patient dependent, right? What they feel most, they can tolerate the side effects and also what's having the best impact. Because I've had folks who go from olanzapine to Risperdal, and it's like night and day, or vice versa. I tend not to use olanzapine as much because of the weight gain and metabolic impact. But for some people, they've been on it for like years and they really don't have any effect in other medications. I've had to get into that whole informed consent process, managing the risks and the benefits of keeping them safe and with reduced symptoms, while also knowing that it may be causing other factors. And what's not on the screen is negative symptoms. We don't have any good therapeutic intervention currently to address negative symptoms in schizophrenia and spectrum illnesses, which is really challenging for a lot of folks who come to you like, I feel profoundly like there's this anhedonia, there's this withdrawal, affective bluntness, all this that they're dealing with, but there's no way that our medications right now are really targeting those experiences. So that's a really huge area of research that we need to really think about more. People try to add little adjunctive things to kind of help people. I've seen people add like modafinil or stimulants or other things kind of perk people up, but there's a very limited evidence for that. I've seen folate, a high dose be used to perk people up, but that's another thing that we don't have treatment for that you may see people presenting with in front of you.
Yeah, sweet. So I will say for me, like what I noticed on this list, like risperidone and paliperidone have some pretty good control, and they end up being like in the middle of the metabolic list. So that's why risperidone and paliperidone are my favorites to go to, because their trade-off of side effects to benefits for like a first line is pretty good. Aripiprazole, which we use a lot, because it's easy to dose and does a lot of things. It's just important to know it may not be as best at controlling psychotic symptoms as some of these other medications, but it is really good for someone who has some weight or metabolic issues. So what are you going to do? So there's no really evidence for any of this, but this is what I recommend doing. So, olanzapine, because it's one like more potent ones, it's great to use as a PRN. So if you have someone who's like in the weekend, the ED, whatever, olanzapine PRN is great for like short-term sort of symptom management. But what you want to avoid, and I've seen this happen a bunch of times in the hospital, is that it starts off as a PRN and they're like, oh, let's keep increasing the dose. It's their first time they have a psychosis. And then it's like, they're getting better control. And then they get stuck onto a daily dose. And then they're like on a full dose of olanzapine. And this was like the first treatment for the first line psychotic break. So olanzapine is not a first line treatment for this. We usually use other antipsychotics first. So if you're ever thinking that someone needs a daily dose of a antipsychotic and it's like their first psychosis that they have, don't use olanzapine, use one of the other ones. I really appreciate or love risperidone and paliperidone for ongoing psychosis. One of the nice things is it allows for injectable dosing. You can do both oral and injectable, and they have a good balance of efficacy versus side effects for these situations. Aripiprazole, just note, might not be as potent for psychosis, but it's really good when there are metabolic issues or concern, and it's also available as an injectable. Clozapine is an amazing drug. It works very well. It's highly effective. It's also one of the antipsychotics where there's studies that it reduces substance use and cravings. But the monitoring for it is this crazy. You have to do weekly blood draws. I mean, weekly, once a week, you have to go in there for 6 months, and then you do 2 weeks for 6 months, and then you can do once a month. And you have to do a lot of cardiac monitoring. And the more intensive monitoring is in the early stages of clozapine when someone might be like more chaotic. So it's very difficult. And it's also only available as an oral formulation, but it is something you could consider for the right person just because of how well it works. All right. Psychiatric medication updates. What we did here, we just like picked some like meds that we really loved, like that recently kind of came out. This is a highlight, and also thinking the ones that your patient's going to ask you about. So we're going to go just run through a bunch of them so you know they exist. So the first one is dextromethorphan with bupropion. The brand name is Auvelity. This got a lot of attention because it was a new novel drug. It's an NMDA receptor antagonist. So this is actually similar to ketamine, how it works, but it's like a very lighter like dose of it. The bupropion causes a drug interaction with the dextromethorphan. It doesn't have a whole lot of active antidepressant use in it. It's just used to boost up the dextromethorphan. The bupropion is a really strong 2D6 inhibitor. So it like boosts, I think like 40%, some crazy number. But the main thing that separates this out from some of the other drugs that we have, it has a very rapid onset. So people notice there's differences in week 1, week 2. So this is what it's kind of known for, what famous for is a very rapid onset. It hasn't been compared to like other like antidepressants, so we don't really know how well they work like side by side, but they kick in faster because the other antidepressants, you know, they take like more like 6 weeks to get to like these maximum effects. But the highlight with this, and this is, you know, important to tell patients when they ask about this drug, this was not effective in treatment-resistant depression. And a lot of folks are going to be like, oh, there's new novel action. And I was like that too. It's like, oh, something new. And it did not work well. I think we're still trying to figure out where this drug belongs in the treatment algorithm of things, but it's probably much earlier on than sort of a treatment-resistant depression kind of thing. It's expensive. It's $1,200 a month. It requires a PA. I was able to get it covered for one person, but it's out there and people do ask about it. So just know it's there. It's also BID dosing, which also might not be great for a lot of folks. And then as people ask like, hey, those two drugs are generic, like, can I just like, you know, avoid the $1,200 cost? You sort of can. There are some folks who advocate sort of doing this. Remember, there's no data on this, but I also get like people need care, not excuses. And if you like can't get $1,200 a month and you really need to get this, you can go like off label and prescribe the 2 items separately. There are some organizations that consider doing this. My favorite, Carlat group, they're like this like psychiatric educational service talks about doing this. Some of the other perks that if you do it this way, sometimes the bupropion, you can dose it in the morning and put all the dextromethorphan at night to kind of like control side effects and sleeping issues. You can do it at your own discretion, figure it out, but people ask about doing generics for this version of drug. Yeah. Sheila, do a shout out for Viloxazine.
Yeah, so this is a really exciting drug for me, Qelbree, because I have a lot of patients who are diagnosed with ADHD, but have some significant contraindications to being on stimulant, whether that's an active eating disorder, whether that's a cardiac history, whether that's actually a history of psychosis, as was already discussed. I feel like Qelbree is brand new to 2022, and it has been shown to be actually really effective as an ADHD drug. It's non-stimulant and it's not controlled. So you don't have to check cures when you prescribe it. And there's been no evidence of misuse or abuse so far. I think that, you know, the study that came out when it was first approved showed that 41% reduction of ADHD symptoms compared to placebo. It's not cheap. It's cheaper than the one that Pierre just talked about of Letty, but it may require a PA. I have a few patients that I have on this, and they've had actually positive effect. You can start at 200 milligram and kind of go up by 200 every week or so to about 600 maximum. I've had people at 400, 600 with better effect, but I think it's something for people to know about as you're having reticence around, you know, should I start someone on Adderall versus, you know, Ritalin, and there's a lot of, you know, societal discussions around these stimulants because number one, there's a shortage nationally. You may have had that patients they're looking at pharmacy all around the city, figuring out who has Adderall, who has Vyvanse. It can be really chaotic. And also again, worry about the history of dependence, the history of misuse, and also the fact that for some people, it may not be the most indicated medication given other factors. So Qelbree, emerging.
And it's fun to say. Next one, aripiprazole extended release. This is really cool. This came out in March of last year. It's the same aripiprazole that we've kind of like, you know, have been using, but it's a new formulation where you can do an every 8-week injection. There's a busy little graph there that shows the PK levels of doing the single 2-month injection compared to monthly injections of aripiprazole Maintaina. This is like approved for bipolar 1 or schizophrenia, but like if you were going to use it for you know, schizoaffective or whatever disorder you're going to do, it would be fine to do as well. But it's a single injection. It's ventrogluteal. You can't do it in the deltoid, but it lasts for 2 months. And what's really cool with this is that, you know, for our folks now who are doing more like Cabril injections and doing those every 2 months, you can match this up so that they just get this like Abilify injection along with their Cabril, and they get like 3 shots like every 2 months. And that could be like a good base for their care. It comes in 2 doses. there is technically a need for oral overlap of aripiprazole. This is all to kind of boost up the drug. At the end of the day, if you have someone who just like stops doing it, it's not like it's contraindicated to just take the injection. It just helps to get the drug levels to where they need to be. And if all you can do is get the shots in, do it. It'll eventually get to the right drug. Just know it's going to take a while, but normally you want to have a 14-day oral overlap for these medications. And there are 2 doses. The full 960 is the standard dose every 8 weeks, but it also comes as a 720 dose. And just to kind of be aware of, there are some drug interactions like that Kobe that comes and bites you in the butt every time that you're not thinking about it. Kobe can boost up the aripiprazole. So, if you have someone on that, you can use the lower dose of the 720 for that. And then, my new favorite exciting one, a new buprenorphine extended release. So this one's the brand name is called Brixadi. It just came out a few months ago. It is the exact same buprenorphine. There's nothing different about the buprenorphine, but what this one separates out from other formulations is that you have more treatment options. There are weekly formulations of this buprenorphine and then monthly formulations of buprenorphine. So it gives you a lot more customization for the dose, though I feel most people just tend to be on the maximum dose of buprenorphine because that's just what they need to be to feel okay. But you have more options around it. But what's really exciting about it is that the volume size of this injection is small. Sublocade, the other extended release that we have, is a great drug, but it has a 1.5 mil injection volume. It is a very painful injection to do sub-Q. And this one's only like 0.16 to 0.64, depending on what dose you're picking. So it's a less painful injection. You have more injection site options. You can do your abdomen and the thigh. Technically, you can also do the back of the arms, but you absorb less on it. So you do have more options a bit with it. And the only other thing to think about is like the monthly injections, though, might not give you as high of a buprenorphine level as Sublocade, but we don't really know what that means or that happens with that. And another little weird thing to do with that, this is also highly controlled REMS, like patients can't touch this med. It comes directly from the pharmacy. And one of the things that we learned is that they deliver it to your DEA address. So whatever you have on your DEA license, that's where they're going. And so some of y'all folks have it at your like administrative office or some other place like that. So that means if that's where your DEA is licensed, that's the only place you can receive this buprenorphine. So you have that updated to the clinic so they can get delivered to the clinic. And then the other very exciting about this is the potential for using this for buprenorphine starts. Putting people on buprenorphine is very, very difficult. The traditional way of like making people wait till they go to withdrawal is like kind of crappy, doesn't always work well, and it helps people suffer. Microdosing is great, but you really need someone who knows what they're doing. It works for the most part, but can be hard. It's easy to kind of mess up. But this was a study that was done in the ED. They had about 1,200 participants. I think it was also done in Highland, so like real world people that we know. And there was a lot of folks who were using fentanyl. And what they did is they waited for people to have a COWS of 4, and they got randomized to like getting like the standard buprenorphine stuff or like a 24 milligram weekly dose of buprenorphine. And it worked very well. They only had like 5 episodes of precipitated withdrawal in the sublingual group and 3 in the XR. And if you look at the little PK graphic, it kind of makes sense. You can see how sublingual group, the little squares, spikes up very quickly after like an hour or so. And that huge spike is what kicks off the fentanyl and causes you to have a lot more precipitated withdrawal. And that's why we try and do microdosing. But this injection, you give it and it like slowly goes up over like a couple of hours, which is what you would love to have for this. And so like, it slowly goes up after 8 hours and it's much more gentle. So in the study, people got this injection and then they came back 3 to 5 days later and got like another injection and it worked very well. So I'm excited about this. I think there's enough data to try this out. I don't know if anyone has. We've been trying to get someone to do it, but I think this would be a great way to get people onto buprenorphine in a more consistent and easy way. Oh, and I did want to give a highlight just while we're on the topic, a couple of methadone updates for folks who did not hear this. There were some new updates to make methadone access easier for folks starting April 2nd. Methadone highly regulated, very hard to get for a lot of folks, but there are new rules that kind of came out from COVID that got to stay that now allows for like NPs and PAs to provide methadone. We can now do like telehealth. You don't need to have an opiate use disorder for greater than a year to access methadone. The initial doses can be higher than 50, like they were like, capped before. The counseling is no longer required. You can access methadone without having to do counseling. And then the huge one is that take home. So doses, people don't necessarily have to go to the methadone clinic every day anymore. As long as they're kind of stable and they're doing okay, they can get 28 days after a month. That's like really cool. So they can have a regular life and kind of get it like like they would any other medication in their pharmacy. So coming April 2nd, methadone, really easy to access. because it's always important to remember we're still having an overdose crisis here in San Francisco. We had 66 people die last month. And then also to highlight the huge racial disparities that we're seeing in overdose rates, where people who are Black and African-American have tremendously higher impact from overdosing. And we need to do a better job of helping people and getting people care. All right, MDMA. Sorry, I know we started to go fast on there. Segue. That's perfect. It's all great. So MDMA for PTSD. MDMA is coming out next year, so it's all exciting. If you hear the company Lykos is basically what MAPS was. They renamed themselves to Lykos, and it's expected to come out in August 2024. And what MDMA therapy, and I just want to because people are going to ask about this, what this actually looks like. You get screened and enrolled, you do 3 of these intake preparatory sessions, and then what an MDMA day looks like is it's all day thing. You have 2 licensed providers who are in the room with you, and you get these doses of MDMA, and you get a little booster dose. And then after you do that day, you get 3 integrative sessions. So you do 3 visits, then you get a dose, and then 3 more visits, and then you repeat that. It's very, very intense for people to do. But in the studies, it was freaking amazing. It had an effect size of 2.1. I don't know if that's going to stay true in the real world, but it's freaking amazing for PTSD. And when you compare that to our existing medications like SSRIs, only have a 0.31 to 0.56 efficacy for PTSD. It's insane. And 67% of the folks no longer qualified for a PTSD diagnosis after they did the 3 sessions. And you can see there on the graph in the red, the MDMA assisted therapy plummeted after every single one of those MDMA sessions. But there are a lot of questions about what's going to happen when this comes out. There's anticipated approval in August 2024. How will this be implemented? That protocol was intense. It's a lot, very costly to have those 2 providers. Is it going to be that way still? And then looking at off-label use for other conditions, for substance use disorders, there's a lot of evidence for MDMA and alcohol use disorder. And then who will have access? How restricted is this REMS going to be? And then there's this whole weird patent fight kind of going on in the psychedelic world where people are trying to patent their music in the rooms and all that. It's kind of crazy. This stuff all should be generic and easy to get. And then also too, this acknowledging the exclusion of indigenous-led practices. Folks have been doing this for years and centuries and stuff, and then we come out saying, oh no, it's going to be legit. And and so what happens to all the folks who were doing this way before and who were arrested and not able to do it before? So so a lot of questions, but people ask about it. It'll be available August 2024. We think. We just don't know how it's going to be implemented. And the same thing with esketamine. You have these great treatments, but no one's really offering it for people who are on Medi-Cal. And how do we do better to give people access to the care that they deserve? So it's not just people with money who get it. So, but yeah. Yeah.
Thank you both. That was a tour de force of a psychiatry update for people living with HIV. We really appreciate this. We're going to take some questions. We'll start with the audience. Anybody in the audience?
Hi, I was just curious about Qelbree and comorbid depression and people who are on SSRIs or other SNRIs. Can you prescribe them for their ADHD with that, or are there too many drug interactions? Curious about those.
I'll go back to the Qelbree slide. So Qelbree is specifically, it has, so it is technically an SNRI, and I've seen folks use it for depression, but I think the evidence really is stronger for ADHD. I would not necessarily consider it a contraindication with somebody who's already an antidepressant. I have folks who are actually on SNRI and on Qelbree because it made better sense. But of course, with everything, always make sure that you're monitoring for serotonin syndrome. But so far, I don't think people are using Qelbree as an antidepressant, though.
All right.
Oh, thank you. That was really great by both of you. I was really curious about the late onset schizophrenia. That seemed really disturbing and not something I knew. Do you think it's associated with known risk factors besides female, substance use or brain trauma or anything that would give us some sort of clue?
Right. Yes, it is very scary to hear those numbers. I think that the data is 15 to 20%. There are different vulnerabilities. Some of there's family history. Some of I don't see a lot on TBI specifically. I think substance use, as we talked about in SIP, does create a more vulnerable subject that makes you more vulnerable towards these things. Are there associations and correlations? Yes. Is it causality? No one can say that for sure. But it is something to be mindful of. But these patients look a little bit different than those who've had schizophrenia since like, late teen years, right? Someone told me when I was in medical school that schizophrenia was a dementia syndrome, in that the brain has this progressive decline neurocognitively over decades. With these folks, there is some preservation, as I mentioned, with pre-morbid functioning being a much higher level than those who are getting it earlier on. So it looks different. There's less negative symptoms. I would say that they also require lower antipsychotic use to manage them. They don't need as high as a dose as maybe a younger person with schizophrenia. But these are really emerging areas of research. But yeah, it's definitely something that a lot of people have not been taught. And it can be very scary, especially if you're like, I'm still hitting middle age. Am I at risk now? Yeah.
All right. We have a question from online that I'll add to. So someone asked about, what do you think about using mirtazapine for meth use disorder and risperidone for psychosis together for appropriate patients? And I guess I'll tack on to that by asking about, you mentioned serotonin syndrome and thinking about folks using methamphetamine and on, 1, 2, 3 serotonergic meds. Is there a number at which that you start to worry, or you do anything in particular to monitor people?
Yeah, I'll start with the treatments for methamphetamine use disorder, which is that so far there's no FDA approved treatment for methamphetamine use disorder. There are data that shows that mirtazapine, bupropion, actually injectable naltrexone has had positive, at least when it comes to psychotropic options, impact on those that are actively using meth. Now, we need to know like what that looks like long-term, what doses we should try, what combinations we should try. I don't necessarily, I think the question was about mirtazapine and something else.
And risperidone.
Yeah. I mean, I can definitely see an indication for using risperidone to treat the psychotic experiences associated with methamphetamine. I think a lot of times providers are reticent to try a neuroleptic drug because they're like, oh, they don't have schizophrenia, they're only using substances and that's what's causing it. For me, it's about how it's impacting the patient. If the psychotic experiences are really functionally impairing them, we should be trying to address it however we can. And that may involve the use of Risperdal, or we're trying to figure out how to help them, decrease and have harm reduction with their substance use. And the question about combination of serotonergic transmissions in the brain, some studies have shown that a single medication at a high dose could cause that. It could be a combination of other factors. It's important just checking with the patient and kind of make sure that you're monitoring them and seeing what potential side effects they're having and informing them of what that could look like. So they actually have that ability to actually let you know, I'm having the tachycardia, I'm having these, experiences. I'm, like this. There's a lot of ways in which we can encourage patients to let us know what their experience with the medication. But I will say that, I think combination of medications I wouldn't like MAOIs, which nobody's using these days, with an SSRI, definitely that has been shown to be not a great combination. So there's certain medications that we know are not good together, but for individuals, it can really vary.
Thank you. We're going to stop here. That was absolutely fantastic. Thank you so much.